So I am not a radiologist, so I thank Dr. Gemini for having invited me and KSOS. So yes, I thank Dr. Sai for excellent overview. So I request you to clear our doubts even after this, if any. So I'll quickly run through it. We have limited time, and essentially it contains all the things. It will be a repetition. So I will take it as a quiz rather than anything else. It's all, I'm doing only cases, and many cases have been shown already. So it's just a quiz. First, congenital anomalies. One congenital anomaly which I would like to stress here for the ophthalmologists is optic nerve hypoplasia. You can see the, the double ring sign, optic nerve hypoplasia. Now why does it matter? It is anyway hypoplastic, vision is less or normal. Now why do we bother? It's a congenital condition, but we should bother. So in the imaging you can see the thinned out nerve, and also you can see normally whenever there is an optic atrophy, the nerve will be thinned out, but correspondingly the CSF will be widened out because the CSF space will be normal as before. But here the entire structure is thinned out. That is optic nerve hypoplasia. But that it doesn't end there. What is more important is a condition called as septo-optic dysplasia or de-Mortius syndrome. These are a lot of findings in this. One thing you should know is there is a absence of septum pellucidum. So what the radiologists call as box squaring of the ventricles. You can see the posterior ectopic posterior pituitary. Sir showed a lot of chiasma and other things. We have the chiasma here. This is a ectopic posterior pituitary. Normally the posterior pituitary is bright because of fat. Without contrast it will be bright. Anterior pituitary will not be bright. But without contrast you can see the bright signal which is ectopic pituitary in septo-optic dysplasia. These are all other radiological findings like we don't need to go into that. So we should know this because these children will have hypopituitarism. So we should identify this and we should refer to the endocrinologist or the physician. That's why we should care about optic nerve hypoplasia. So now we should not have given the diagnosis. So now what is the clinical finding is plexiform neurofibromatosis. Plexiform neurofibromatosis. It's type 1 neurofibromatosis type 1. You can see the absence of the greater wing of the sphenoid and the pulsatile proptosis and other things you will have. And what is this condition ophthalmoscopically? Morning glory. You can see it resembles the morning glory flower, and they will have basal encephalocele. So these are the reasons why we should care about congenital optic nerve anomalies. We should care. We have to detect all these conditions. Now this is this again Dr. Sai has described multiple nerve palsies. You can see the Tolles-Ahern syndrome, inflammatory lesion. One point for us ophthalmologist I want to give is this is very glaring in this axial section. Always also look at the coronal section. Coronal section gives a differentiation very grossly, and with this you can clearly see that this area is more hyperintense than this area. Now sarcoidosis has various manifestations to us. It can be optic neuritis, it can be uveitis, so many other things. You can see the sarcoid granulomas in the optic nerve. It can present as optic perineuritis and other things. So you can see the extensive inflammation within the visual pathway. Now again this has been described. So Dr. Sai showed one beautiful dilated superior ophthalmic vein. So for us ophthalmologists we should know that SOV goes from lateral to medial in the upper part of the orbit. So now this is a very gross finding, but any subtle findings, any subtle proptosis, subtle CCF, indirect CCF also we should be able to identify. So this is a gross CCF. You can see the dilated SOV, and this is a chemosis and direct CCF. This is a case of direct CCF, usually due to trauma. One point I want to tell us is we had one patient who had a trauma. He was declared normal. 2 months later he is coming to us with a sixth nerve palsy. Now what is the reason? Initially scan has been taken, everything is normal. Can we say that okay, this is something maybe due to diabetes or something? Can we say and let him go? We should not. Whenever there is a trauma, we should suspect, if it develops late, we should suspect a direct CCF. Why did it not develop before itself? Because at that time the rent is very small, but in the internal carotid artery and the cavernous sinus. So gradually in the course of time, the rent becomes bigger, and directly to show up to us with a sixth nerve palsy or sometimes even third nerve we have seen. delayed presentation. Always repeat the imaging. Suspect delayed CCF, direct CCF in a case of trauma. Now this is primary optic atrophy. So can we say POA, nothing can be done, long standing? We cannot say that. We need to do the fields if possible. Vision is normal. Vision is reasonably good, 6/60. And we should do some form of neuroimaging. So now, 25 years back when I was a PG, and I'm sure some of my counterparts might be here, that time X-ray only. CT scan was 1,500 rupees. That time, my stipend was also 1,000 rupees. You can know this thing. It was very difficult. 1,500 was a big amount those days. Okay, so we will try to avoid CT as much as possible. MRI is out of question. So we used to do a lot of X-rays. So nowadays PGs do not know what an X-ray is. It is an outdated investigation, but there are a lot of valuable information in the X-ray. So you can see the cella, well preserved anterior clinoid and the posterior clinoid, but you can see some amount of hyper density in the basis sphenoid, in the planum sphenoidal region. Of course, this is not enough. But this says that something else may be going on. You can see the dilated meningeal vessels. And now this is a CT plane study. And you see that this is a supracellular cistern. It appears to be normal, but the cistern is filled because there is something else going on here. You see, this is a bright contrast enhancing tumor, a meningioma. This is a isodense. Iso means it is similar to the surrounding brain tissue. So never be willing to accept a CT scan without a contrast. You can very well miss. Look at the supracellular cisterns. Ideally, we are doing nowadays MRI only, but if at all a CT is there, make sure that it is contrast enhanced. So this is again meningioma. Why not it is a pituitary? Because the cellular fossa is not really enlarged and it is more supracellular, slightly asymmetric to one side. And Dr. Radiologist showed that you can see it is extending along the planum sphenoidal, and sometimes you can see what is called as the dural tail sign, enhancing dura along the meninges. And you can see the hyperostosis of the bones because of the chronicity of the lesion. So sometimes you can see this hyperostosis. So that is a supracellular planum sphenoidal meningioma. Next case is a bitemporal hemianopia. Again, it presents with a bitemporal pallor, but here you see the X-ray. You can see the double flooring of the cella. So something is going on in the cellular region, and you can see this is a cellular mass, pituitary mass, which is in the midline structure, which again has been shown. You can see this is a CT, and you see the notch here. There is a small notch here. Why that notch? Because the pituitary grows, pierces the diaphragm, and again it grows. So when you ask them, they will say, 6 months back I had headache, now no headache. When it was piercing the diaphragm, they would have had headache. Now in the supracellular space is very big, so they don't have headache now. So this notch is when piercing the diaphragm, and this shape roughly resembles a figure of 8 appearance, they call it, or a snowman appearance. See, like a snowman, you would have seen this Tintin comics, Tintin in Tibet or something you would have seen. So like a snowman in the Himalayas or a figure of 8 appearance. You can see the notch here, and this is a pituitary adenoma which is engulfing, as was shown by the radiologist, the internal carotid artery. Macroadenoma. Now, as clinicians, my chief used to scold us if we don't identify the clinical findings. Now, we have to identify this patient only by the clinical findings. Now, it is obvious. He has got prognathism, he has got thick lips, he has got hypertrophied frontal area. He is an obvious case of a growth hormone excess. So, similarly, opposite to this, when the patient comes, a 25-year-old adult or a 30-year-old adult comes to us with the male gas, no mush, he appears like a 18-year-old boy. And many times they would have had no children, infertility, they would have been extensively investigated, the wife would have been investigated, so many things. But this guy will be like a young adult or a young adolescent boy, but he'll be around 30 years old. Once I took such a case to my madam, and she scolded me, did you ask for secondary sexual characters? Did you see the pubic hair, whether it is grown or not? I didn't. So I got very heavy scoldings. So these are the things we should know as a clinician. We should look at all the clinical findings for any PG who may be here. I am not sure whether PGs are here. So this is a case of acromegaly. So, and you can see the hypertrophied frontal sinuses and large cellular area, double flooring of the cella. And after tumor excision, residual, you can see the chiasma, some residual mass is there. Usually they give radiotherapy. So that's a growth hormone growing. So this is a multiple cranial nerve palsy. So now you see the total ptosis. You can see this you see the pupils. Pupils are dilated and fixed. You can see total ophthalmoplegia, adduction, right side. Adduction is limited. All the other movements are limited. It's a proptosis. So it is a case of a orbital apex syndrome or a cavernous sinus syndrome. And this similar case was shown prior by our radiologist. And this is an aneurysm, a large internal carotid artery aneurysm, which is thrombosed. Sir, correct me if I'm wrong, if I make any mistake, any image. Okay, is this correct? Thrombosed aneurysm. Okay. So now again in the MR angiogram, and we all know this aneurysm presses externally on the pupil fibers. And next is a young middle-aged female with ophthalmoplegia and proptosis. And for the PGs, you can see here there's some amount of chemosis, some amount of lid edema. So this is telling that it is not a straightforward inflammatory case. And her blood sugar was 400 milligram %. Now what is the diagnosis? Is it an inflammatory orbital apex syndrome? Likely not. You can see now, we can see the dilated superior ophthalmic vein here as compared to this. And you can see the axial view dilated superior ophthalmic vein. And what else can you see here? You can see this is a cavernous sinus and there is a filling defect. You see the opposite cavernous sinus and here there is a filling defect. Now she has got a high blood sugar and proptosis, ophthalmoplegia. We have to make a diagnosis of a cavernous sinus thrombosis. We should not give steroids here. Next, multiple sclerosis has been shown, either normal fundus or an optic disc edema. Sir has shown the Dawson's fingers, perpendicular fingers and the skipped lesions in the spinal cord. All these white matter lesions has been seen. And these are another type of tumefactive necrosis in a multiple sclerosis patients. It's good to know, as ophthalmologists, it's good to know some of these things. Papilledema we have seen, you can see the dilated optic nerve in the CT, but MRI will show the CSF as well as the nerve. There's a dilated the perioptic nerve space which is seen in the CT with in the MRI T2 sequence. You can see, whereas CT you cannot differentiate the nerve and the CSF surrounding. And you can see the dilated perioptic nerve sheath. And early papilledema we have seen, mild papilledema. Now there is a fallacy here. Any papilledema can potentially harbor a venous sinus thrombosis. Now this is a case of in a CT of venous sinus thrombosis. You can see hyperdense lesions here and hyperdense lesions here. But ideally we should do an MRI scan. And here in this CT you can see a filling defect with contrast. This is without a contrast, plain study. And if you put a contrast in a CT, you can see a filling defect. It's called an empty delta sign. And you can also see the superior sagittal sinus, a tram track sign due to the filling defect in the superior sagittal sinus. In an MR venogram, this is a normal venogram. You can see the absent signals, the MR venogram. And MR venogram is ideally, it's a non-contrast study, but nowadays they put contrast also, they give. Now this is seizures followed by field defect and homonymous hemianopia. So any seizures, any in the occipital lobe or in the parietal lobe, in the intracranial lesions, you can see what is here is a cysticercosis. So it is a cysticercosis in the posterior parietal lobe, which is causing the field defect as well as the seizures. And again, this is a diffusion weighted hyperacute infarct in the right occipital lobe, which is which may be showing a left homonymous hemianopia, which is sudden cortical blindness, bilateral sudden vision loss due to cortical visual impairment. Thank you very much for your kind attention.